Hello, I'm Dr. Shlomit Schaal. I'm the Chief Physician Executive here at Houston Methodist, and welcome to our Women in Surgery webcast, where we highlighted some of our best surgeons here at Houston Methodist. All of them just happen to be women. And today I have a wonderful guest here, Dr. Nicole Tapia. She's a general surgeon and a critical care surgeon. Welcome to our show, Dr. Tapia. How are you?
I'm doing great. Thank you. Very excited to be here.
So tell us, what is a critical care surgeon? What is a general surgeon?
So a critical care surgeon is a surgeon who's board certified in critical care, which is a separate board from general surgery. That means that I am able to take care of ICU patients that are in our highest level of care, that might require being on a breathing machine, might require vasopressors to maintain their blood pressure, special equipment in their room, and require the highest level with the lowest sort of patient to nurse ratios.
So you did tell us a little bit about your journey. How did you get to be what you are today?
Sure. Well, I grew up in the suburbs of Houston, so I am from around here. And I went to undergraduate at UT in Austin, and then I continued the UT sort of journey in San Antonio for medical school, and then came to Baylor for residency and then my critical care fellowship. And then I stayed in town. My family's all here, and I was able to find a great job right out of residency, out of fellowship. And then I did that for about 3 years. I was a trauma surgeon, and then proceeded to come here.
Well, you were a trauma surgeon. We'll talk about that in a second, but just tell us a bit about, during your medical school class, how many years ago was that?
So I started medical school in 2005 and graduated in 2009.
So relatively recent. I mean, comparing to my journey, which was like 30 years ago, this is relatively recent. How many women in your class went to general surgery?
Ooh, I wish I had those numbers. I don't know that there were that many of us, actually. More people went into other medical specialties and subspecialties, or pediatrics, gynecology, that type of thing. In my close core group of friends, probably about 4 or 5 of us total were surgeons, including one of my take mates who swore on the first day she did not want to be a surgeon. But I saw her dissecting the tissue, and I kind of thought otherwise. And she was a general surgeon too. So not a bunch of us, actually.
So how did you decide you want to be a surgeon?
When I grew up, I always like to joke that I came out of the womb saying I wanted to be a doctor. I wanted to be a pediatrician as a kid because that's what I knew. And then I don't know if you remember the Learning Channel, TLC.
Yes.
It used to actually be a learning channel. And there were really interesting shows with cases and things like that, less reality TV and more medical stuff and other things. And so I grew up watching those. I thought those were really interesting, really great. Turned out that I liked surgery. And then when I started in medical school, doing my first surgical rotation, I was hooked.
So no one in your family was a kind of a role doctor, model for you, like a father, mother?
No. First doctor and first surgeon in the family.
Wow. And tell us a little bit about your family. Do you have sisters, brothers? What kind of family you come from?
So very blue-collar, working-class family. Grew up with a family of, we have 4 of us kids grew up together. My dad worked at a chemical plant. My mom was stay-at-home for a good number of years. Actually, when I got my first job at 16, she went back into the workforce after a long time at home raising us. And, just a very simple kind of straightforward upbringing. Didn't have any mentorship in the medical field, just worked hard to get here.
So what was their response when, you said, okay, I'm going to medical school and then I'm going to be a general surgeon?
They were very proud, which, I think that's kind of obvious, or hopefully that would be obvious. But it was very sort of self-directed. They didn't know how to navigate that sort of arena. And so I had to, use the counselors, use a lot of, researching on my own, apply, figure out how to get here.
So you were determined, you knew you want to be a surgeon, but that was not enough. You wanted a subspecialty or another fellowship. So how did that come about?
So when I started residency in general surgery, I thought that maybe I would do, surgical oncology, breast, something like that. I knew I needed to do some research, so I matched what's called a research track, where I do a couple years of clinical, interrupt that and do 2 years of research and then do another 3 years of clinical. So my residency was actually 7 years instead of 5.
How many of the residents do this thing?
So in my program, half of us do. A lot of programs across the country, some of them require research years, or some of them ask you to volunteer. This one, I specifically matched to the research track. So I figured I would want to do research for whatever sort of career I had. And then surprisingly, when I started in residency, I fell in love with trauma. My sort of first time in the ICU as an intern in the trauma ICU, I thought it was really incredible that these very sick patients could have horrible things happen and walk out alive and get better and do really well. So I fell in love with trauma and then proceeded to do some trauma research at Bentop across the street.
What was your research about?
I did a lot of things, but I did research on resuscitation of trauma patients using what's called hypotensive resuscitation. So that is the premise that you want to not really drive up people's blood pressures after they've bled, because you might pop whatever clotting they've already done. I did a lot of resident education research and then some handoff research. So how do residents hand off patient care safely?
And this research was published and it helped you get into your fellowship, is that?
Yeah, so I had a pretty productive career. I think I published maybe about 7 papers during my research time and the rest of my residency. So it was very beneficial for that and makes you a good candidate for fellowships.
And so tell me a little bit about that fellowship decision and how long was the fellowship and what did you learn?
So in the trauma sphere, depending on what level trauma center you work at, level 1 trauma centers, they tend to like the attendings, the staff, to be boarded in critical care. That way you can not only take care of your trauma patients in the operating room, but you know how to manage them well in the ICU too. Because that sort of pathway for patients is very common. You get really sick, you go to the OR, and then you go to the ICU to be taken care of. So I decided that I wanted to do that type of fellowship. There's 1 year and 2 year options. I did a 1 year fellowship at my same institution and really learned how to take care of trauma patients from start to finish.
Is it stressful to be a trauma surgeon? I mean,
Definitely. You never know what's going to come in the ER. They talk about something called a golden hour in trauma. So you really have a short period of time from the patient's injury to make the most impact and to save their life. You are stopping bleeding, you're giving them blood, you're resuscitating a patient, you're trying to figure out what's wrong with them through diagnostic testing, or you take them straight up to the OR and operate.
So when you start that trauma fellowship, you're already a certified or board certified surgeon, or close to the end of
at the end of your training period,
yeah.
Yes.
So you already trained for several years, in your case 7 years. Then you become a fellow, and during that fellowship, are you the captain of the ship, or are you just watching how other people do it?
So during the fellowship, you're definitely the captain. You are running the ICU with the junior residents, rounding and coming up with plans. And then because we were already general surgeon trained, we were able to take call as the general surgeon in the hospital with the backup of our attending who was there, but they rarely had to come in and help us unless, there was something that was really critical. So it's kind of a nice way to start off with a little bit of training wheels, a little bit of a safety net as you're taking care of these very sick patients. We were on call every Thursday night. You knew that was going to be your time, Friday morning, your post call, and then, going into your weekend.
And you are, a woman in a very manly field. Still today, there are less than half surgeons, in some places way less than half. I know that here at Houston Methodist, we're actually more than a third of female surgeons. But in that fellowship where you're young, relatively young in your profession, and you come and, these are really stressful situations where you said you're the commander, there are many, many other people, everybody's looking at you. Did you have an imposter syndrome at all?
I think everyone has imposter syndrome, but I definitely, your job is to save the patient. Your job is to get them better, to fix whatever the problem is, make the bleeding stop. So that sort of imposter syndrome goes out the window when you're focused on what your task is. And so it wasn't, really an issue, I don't think, so much in fellowship.
So do you do kind of an M&M, replay what happened, learn from it, and, people criticize you? How did that go for you?
I think that M&M is really important because you want to always look back and see what you could have done better. And I think that criticism is really important. If there's something that was done wrong, it may not affect the person's life who you are treating at that moment, but if you can learn from it, maybe it'll save someone else. So I think that those learning opportunities are really important in learning and in patient care and in quality, and in having what we call like a just culture. You want to look at how your patient did or what sort of complication occurred and look at all the aspects of it. So you want to look at, was it a technical issue? Was some of it, just the baseline, how bad the injury was? Was any of it systems issues? Were there delays in getting the patient the care that they needed? And so when you can look at it like that with a sort of clear head and, taking the emotions out of it, I think that's important and helps us all sort of advance patient care.
But who gives you that criticism? Is that your mentor? Is that everybody else in the department? Who provides that feedback?
So usually M&Ms are done with your department. So you're standing up at a podium, you're looking at all of the, attendings in the room, and, you're answering questions and fielding questions.
So did you sweat the first time or?
I think the best way to go into those situations is to just be overly prepared. Know the case, know the details, know the data, and defend what your decision was at the time. But also don't be afraid to fall on the sword if you did something wrong. The worst thing you can do is, argue against something that is not ultimately true. If you messed up, you have to be accountable for that and say, oh, you know what, I didn't do this right this time. If I was doing it again, I might have tried this, that, or the other.
So in trauma, because it's so fast, everything is moving so fast, there's not a lot of time, to think about it at the moment. Where you said that, at the moment you're just in it. But then every case is reviewed or only specific case? How does it go? Because I think, you want to be better from case to case.
Sure.
But do you review every case?
So whenever we do our M&M, we actually would have all the cases on a protocol and sort of what their injury was and what was done and that type of thing. Most of the triggers for case review are if there's a bad outcome. So if the patient had a death, if the patient had to go back to the OR within 24 hours, if the patient had some unintended event, maybe they went to the floor, but then they were admitted to the ICU and that was unexpected, or they had to be intubated for some type of reason or needed some procedure. So there are usually triggers that help us to focus our attention on those things that can be done better. And that's usually how it happens in an M&M type of situation. But of course, anything is a free-for-all. So if there's an interesting case or an interesting diagnosis, that that's up for grabs and you need to be able to talk about it.
And in that room, when you do the M&M, who is there with you? Obviously, all the physicians,
Sure.
right? But who else?
So all of the surgeons and the staff, residents, medical students, whoever's on the service at the time. So there's lots of levels of learners, which I think is really important. And it's a safe space. So it's not supposed to be cases and things that are talked about outside of the room. You're there to talk about how you can make the patient care better, not to point fingers.
And this is only physicians, or there are also nurses and other
Usually
team players?
it's mostly physicians, but sometimes nurses would come and other aspects of the care. It wasn't a closed room and that no other medical professional could be there, but it was usually primarily surgeons.
And then, we see a lot of kind of TV, right? And you talked a little bit about reality TV, but, there's a lot of doctors' shows and things. And, I watched them growing up and then realized that it's not exactly the same, But are you there alone as a physician? Or is there like a team of physicians that come and take care of the patient, trauma patients?
So it's definitely a team sport. That's one of the big things I say about trauma. Trauma is a team sport. Everyone has a role. It's organized chaos.
Who's the commander?
The trauma surgeon.
The trauma surgeon.
Yes.
But there are other physicians.
But there are other physicians. There's ER doc that's usually at the head of the bed. They're getting the airway. There's nurses that are getting IVs. There's respiratory therapy who's helping with airway if that's needed. There's residents that are turning the patient, doing the head-to-toe exam. The attending is usually at the foot of the bed, kind of overseeing everything. You can see the vitals, you can see the patient, you can see what's going on, and try to put together all the pieces.
Here at Houston Methodist, we're very big on innovation. I know we have cameras now in every patient room. We have cameras in our OR. I'm curious about trauma. Do we have them in the trauma bay? Do you watch videos and review what happened, afterwards by video?
So where I trained, we didn't do that. We didn't have the technology at the time. Our trauma hospital is Ben Taub, which is the county hospital. But there are hospitals across the country and training programs that do camera recording in the trauma bay. And so they use it to look at sort of response times, do the right teams come in, if something happens that is, not ideal, were there any circumstances around that? And they, will audit those and sort of see how responses are to trauma and if they're appropriate and if the different members of the team are being efficient and doing their jobs.
So what does the literature say? These teams become more and more effective with time reviewing a video? Is that something that people are investigating?
The teams do become more effective with time as far as, response times, making sure everyone gets there, doing things in order. I don't recall, it's been a little while since I've reviewed trauma literature, since I'm not doing trauma anymore, what the exact findings were. But, I think the initial concern was, we have these videos. Is this going to be a way to sort of point fingers? Is this going to be a medical legal issue? That type of thing. But when you're doing something under the guise of quality and improving patient care, and not under sort of a finger pointing, you did this wrong type of way, it's a nice way to assure that everyone's doing what they're supposed to be doing. And maybe you find something unique or unusual that can make things better. Or you take something an element out of the trauma resuscitation that is not helpful. So I think all of those are, interesting things.
So you moved away from trauma to critical care. Why?
So I moved away from trauma to acute care. Acute care is a combination of general surgery, emergency general surgery, and critical care. And mostly because this hospital doesn't have trauma. If they had said, come here and do trauma and acute care and critical care, I would have said, sure, sign me up. But I came here because I missed sort of more of the general surgical cases. In trauma, it's a different kind of approach to surgery. And I did do some general surgery when I was a trauma surgeon, but not as much as I wanted to. I was kind of surprised how much I missed that aspect of it. So when I was recruited here, Dr. Gaber, who is our chair, and then Dr. Martinez, who's my division head, they sort of explained sort of how cases are and things like that. And although we don't have trauma here, we do have very complex disease. We have patients with significant comorbid conditions that increase their risk for surgery. We're basically a tertiary or quaternary referral center. So we're the hub. Patients at other hospitals don't think they have the capabilities to take care of, get moved here for a higher level of care. So although it's not trauma, it still has that sort of intrigue to it. It's really interesting cases. It's really great patients, and it's people that you really want to make a difference in.
So these people come through the ED, all of them?
So not all of them. So we take ER call. We take about 85% our group of the ER call for the hospital. But when we're on call, we are also fielding calls from freestanding ERs that come into our hospital. We're taking calls from our own ER, and then we're taking calls from other hospitals that either are part of the Methodist system that need a higher level of care that maybe they're not able to provide at that hospital in the community, or from other hospitals from other cities, Beaumont, Nacogdoches, other states sometimes even, that bring their patients here. So I take call from an acute care surgery standpoint about 5 to 6 times a month. And those calls, we usually try to put several of those in our week. That's our inpatient week, when we're going to be rounding on our acute care surgical patients, sort of our service time on that week. And then other calls are kind of sprinkled throughout. And so the calls can be variable. I might be up operating all night if someone comes that's really sick and more than one comes and kind of back-to-back surgeries. Or I might get some calls from the resident staffing certain cases, see them first thing in the morning. Maybe they do or don't need an operation urgently.
So when you're on call, you're at home and being called in.
It's a home call. Yes.
Yes. And tell us a little bit about your home. I know you're a mom.
I'm a mom. My husband and I have a 6-year-old, and I actually had him in my first year as an attending. And so that certainly had some interesting things to navigate. And my husband works in baseball. He works for the Astros. I work here. So the Astros Methodist thing, goes really well together.
He's not a player,
He's
right?
not a player.
Oh,
no, he's not
too
a player.
bad. Okay.
He's not a player. He works in the office. So, it's a fun house of baseball and medicine. And so my 6-year-old goes back and forth saying, Mom, how long did it take you to go to school if I want to be a doctor? And then I tell him, and then his dad says, it only took, he asked his dad, Dad, how long for you to go to school? And he tells him, and he's like, think I might want to do what Dad does.
So do you want him to be a physician?
I only want him to be a physician if that was something he would want to do. I think that if you want to be a physician, particularly if you want to be a surgeon, there's a lot of dedication to it. There's a lot of sacrifice of time with your friends and your family, sacrifice of our youth that people don't always talk about. And so only if he was truly interested in doing that would I encourage it, because I think it's a challenge and you have to know what you're getting into when you come into a career like this.
Any second thoughts for you?
No.
What do you love about it?
Everything. So I really love the fact that it's a lot of times I can definitively treat a patient for their problem. Something as simple as they come in with appendicitis, they hurt, they feel terrible. I operate on them, they go home the same day or the next day. That sort of simple disease and diagnosis, I can fix it. I can cure that problem, as opposed to treating someone with a chronic medical condition that you're maybe doing some medication management and encouraging lifestyle changes and things like that. It's a more definitive approach to the problem. And so I like that. I like that I can fix the problem. It's also very mechanical, doing things with my hands. I'm not sitting at a desk writing notes all day or sitting in clinic all day. It's kind of fast paced on your feet, lots of multitasking. And so that's, the ideal sort of life for me.
Yes, but you talked a lot about sacrifice, and the sacrifice, you talked a little bit about sacrifice in the early year, but you said you have a 6-year-old. I bet you can't, be there for all PTA meetings and things. So
Sure.
Is there a feeling of sacrifice, or how do you feel about it?
I'm very fortunate in that I have really, really wonderful partners that also have families. And so I'm not going to make a PTA meeting, but I am going to make the baseball games. And we all support each other. If someone's got a child that has a school function or something like that, and they need to step out, we cover for each other. And that just works because we have great partners. We're a great group. So that's one thing that I like. Also, I live very close. I'm like a mile down the road. And so if I need to, run home real quick and have dinner with my kid, but then I have an appendix that needs to come out at 8:00, I can go home real quick. I can say hi. It sort of helps that work-life balance. Come back and take out an appendix, and he gets excited to hear that, Mama has to go back to work. What are you taking out today? So
Did you ever bring him to work?
I have. I've brought him to work. So when we had the hurricane and we had no power, we were staying at the Marriott or the Westin. It was very close by, the one that's right here. And so after hours, we came over and I showed him the robot simulation that we have in the resident workroom. And so he got to play with the robot and he loved it. And so he still asks, we've done it a couple times. He still asks me when he can come back and play with the robot. He thinks that's great.
Fantastic. You had the robot training when you were a resident, or?
I did not. So I actually started robotic training as an attending when I started here. When I was a resident, I didn't like the robot because—
Why?
Well, because I wanted to be a trauma surgeon. So to me, I thought the best incision is the biggest incision. And
Is it true or not?
No, it's actually not. I actually completely disagree with my younger self now. I love the robotic surgery. I love the minimally invasive platform. I actually gave a grand rounds about it this morning, how we sort of grew our robotic surgery offerings to our patients. We grew robotic surgery within the acute care division, but then we also grew our resident education on that platform to make sure that they know how to be safe, be efficient, and can be good surgeons.
You're teaching residents now. Do you have female residents as well?
I do. We have a lot of them. We're almost like 50-50, female and male.
Fantastic. Do they look up to you and seek your advice?
Well, I hope so. I try to be a good mentor to all my residents, male and female. Obviously, I can address more female-specific concerns.
What do they come specifically to you or to your female colleagues with?
Well, for me, I think the fact that I'm a mom is helpful. I've had residents that have had pregnancies during residency. As soon as they get pregnant, I sort of give them a lot of resources about, there's physician mom groups on social media that I hook them up with, things about lactation, breastfeeding, all sorts of things that I think are really important that, even as doctors, we don't get a lot of good education on certain things. And as a surgeon, we certainly don't. So those are things that I sort of help them with and helping them kind of navigate, coming back to work. What's that going to look like for you? That type of thing. So I try to offer, advice whenever I can, and hopefully that they appreciate it.
Fantastic. And I know that some of them are going to stay in town and some of them are going to go and take care of patients all around the country and maybe the world. And it's very fulfilling.
Definitely.
So tell me one other thing that I'm really curious about. So you told us about your incredible journey and how you did many things that probably other people, you did research, you did training and extra training. You did it also as a mom. You were pregnant as an attending and then delivered as a young attending. And now you are an attending surgeon, a teacher. This journey, if you had to give advice to somebody who's watching us today who is in medical school, any advice, any insights, what are you most proud of? What brings you most joy in your work?
So I think, one piece of advice I would give a medical student, a female medical student, is if you're not sure if you want kids at the time, freeze your eggs. That is one of the unspoken things that women in medicine and women in surgery talk about now that we were never talked about whenever we were in the education kind of side of things. When we were learning, when we were coming up and starting medical school, a lot of my friends have children in high school and college now, and I have a 6-year-old, my friends from high school. So, as we get older, we know that our egg reserve gets lower. There's a higher risk of, infertility. And so I think one piece of advice I would give medical students and residents is, to consider that if that's something that you can do. And I say that because one of my good friends in residency, she did that. I've known other people in residency to do that as well. And, some residency programs and some health insurances actually have funds for that to help people. And so if you can do that and take advantage of it, and that's something you're interested in, consider it, because you may not be able to get pregnant later when you think you're going to finally be able to try. So I think that's one piece of advice that no one really talks about. It's kind of taboo to talk about fertility, things like that. But I think it's important to have those open and honest conversations of what to expect. The other piece of advice I would give is just go for it. Like if you're going to do it, you want to be wholeheartedly, fully dedicated, committed to whatever it is that you want to do, whether it be surgery, whether it be medicine, any subspecialty. I think that if you're passionate about it, if it's something that, you're going to love, you think you're going to love, you really want to take care of patients, don't let anything hold you back. Use all your resources, use all your connections, do your research, be diligent, and really just, be, I think what the word is.
Committed, maybe.
Committed. Yeah. Be committed and persevere. I think there's going to be hard times, but you want to always persevere.
So what's next for you? I mean, you talked a lot about that journey, long journey, but you're so young. What's next?
Well, I am really committed to resident education. So I'm recently got a grant with one of my colleagues, with my division head, Dr. Martinez. We're teaching resident robotic surgery. We have a grant with the Mighty Lab here in Houston Methodist. So that's one of my, concentrations. I'm very passionate about resident teaching. And the other thing that I do a lot of is quality. So I'm the NISQIP surgeon champion for our hospital, looking at quality outcomes for our patients. And so those are sort of my two kind of core things that I'm looking at, that I'm growing, and those kind of all go hand in hand with research.
That's fantastic. And can you tell us specifically what you want to do in resident education, maybe that you didn't have, and certainly surgeons in my generation didn't have?
So I think in resident education, my focus right now is robotic surgery. I think that there's a lot of research that talks about what should be taught, but it doesn't talk about how it should be taught. And so I'm working on sort of video series, things like that. We didn't grow up with YouTube.
Right.
So trying to implement videos to teach residents in a way that they like to learn, which I think is different than what I grew up with. That's one of my current sort of goals and passions right now.
So a lot of people say the younger generation is not like us. I'm sure that they said it in every single generation. Do you feel that way at all? Or, how is our young generation of surgeons? Are they good? Are they going to be able to take care of me?
They are. They're wonderful. It truly is a privilege and a pleasure to be able to take care of them. It's wonderful to be a part of their journey. It's really fun to see them start as junior residents, where they come in and they're just trying to find the bathrooms, up to being leaders in their amongst their peers, leading teams of residents, taking really good care of patients. I think that we're going to to be okay.
Thank you, Dr. Tapia, for joining us today. I very much enjoyed our conversation. I'm leaving here with a sense of hope that the future of general surgery is bright.
Thank you so much for having me.
And thank you for joining us today. I hope you enjoyed as much as I did. See you next time.